Welcome to the third and final episode in our NHS podcast series featuring Andy Kinnear and David Kwo, both digital healthcare consultants and former CIOs in the NHS. In our first two episodes, we discussed Andy and David's backgrounds, what led them to working with uPerform, the Darcy report and the current challenges facing the NHS, as well as areas of opportunity for improvement. In this episode, we'll dive deeper into solutions the NHS can start employing now to optimize the use of technology and discuss where uPerform could fit into that strategy.
Thanks, Harm. Andy, you and I have often discussed the challenges of digital transformation and specifically the people element. Understanding how tech will impact, for better or worse, the people who end up using it. And I think we both agree that too often this is left to consider after something has already been turned on. What are the strategies you would like to see utilized to turn this around? So we start thinking about that on the front end rather than waiting until things have already been implemented.
Yeah, exactly. The first thing to do is to make that important. So to make that an important part of the process. And I think what we've seen, the shift we've witnessed over the last year or so in England, at least, has been a focus on optimization of technologies that we have deployed rather than a focus on funding and deploying technologies in the first place. So the conversation is shifting from being about business cases for EPRs and the deployment of EPRs into our hospitals, more to about, are the clinicians satisfied with those EPRs? Are they happy with using them? Critically, from a uPerform point of view, I guess, are they skilled? And do they have the level of mastery of the system itself? And so I think what's pleasing for me, at least, is the cultural journey is starting to shift away from delivery of technology to optimization of that technology. And I think that I guess is the first step. I think the second step is that it feels like this conversation is now underpinned by evidence. So rather than it being received wisdom around the way we could do things differently, and so in the case of training, maybe we should change our approach to training, and that was just an opinion that our expert spouted out, but they couldn't necessarily evidence. I think the fact that we've taken on the Class Arch collaborative work across the country and have got genuine evidence now, nationwide, hospital by hospital, as to how, satisfied and how happy the clinicians are with their EPR experience. It means we can sort of really target and focus then on those organisations with low scores to say, well, actually, it's not really about the product you've deployed. It's about the way you're supporting your staff and things like that. I mean, a couple of other sort of elements for me. One is that it's really clear there's going to be no new money. The NHS envelope is the NHS envelope, and so focusing on better ways of doing things within that funding envelope is really key. And so this optimization story isn't just a nice to have. This is a fact of life now, that we need to get the best out of the things we've got. And I suppose the last sort of key point for me in this area is that the morale of our clinical workforce is probably, a real low point right now. I think they feel genuinely unloved, and they don't feel like the service is necessarily giving them, their best sort of daily work experience. And I think the digital experience is contributing to that. In truth, they're going in and they're not happy with the systems they're using. They're not expert in their use. And, when your day's already tough, that's another burden on top. And so I think finding new ways to train people to improve their skills and to do it in a way that doesn't feel burdensome, that actually feels supportive. I think alongside other action we take to make people's sort of digital experience as frictionless as possible, then that will be a genuine positive. So it feels to me like there are cultural and financial drivers, I guess, now starting to come into play to kind of drive the focus onto optimizing the people part of the story rather than just the deployment of technology.
So many good points. And like I say, we've discussed this so many times, but there is no new money. There's additional funds, but the people that are there, they have a lot to give. They have big hearts. People go into healthcare because they want to help. And so how do we do a good job of supporting them so that they feel really supported so that they can turn around and deliver the best possible patient care. And I think some of these things don't have to be terribly expensive. Like you're saying, like we can do a better job of supporting them in the organization. We can make sure that they have the skills to utilize the digital tools we're providing them. And those things don't have to cost a lot of money to do, but they can have a huge impact on how people feel. I know that when I have to do a job with any sort of tools that don't feel like they are up to par they're not equal to the task at hand, it really does like weigh me down when I feel like, oh my gosh, like this could be so much better if I had this, or if I knew how to use this. And I think especially in today's day and age where technological tools are advancing at a rapid pace. And so how do we make sure that the people that have the ability to use those tools can do that effectively and feel like they feel very equipped to handle those? So those are my thoughts. David, would love to hear your thoughts on this.
Yeah, of course, I totally agree with what both of you have said. In my travels as well, I absolutely see that there is a recognition, a general recognition that digital technology is very much part of how clinicians treat patients. But there isn't enough attention, as Andy is saying, given to how clinicians should be using these new tools. And the other thing is there are lots of new tools coming along, which is in a way welcome. There are lots of AI tools, lots of data analytics tools. But the problem is, I think we see central governments just tending to just chuck new shiny toys in to healthcare, assuming that they will help things, make things more efficient, but they don't give enough thought to how clinicians will be using these tools. So I totally agree with what we're saying, and I think hopefully as we get more mature about implementing these tools and optimizing, as Andy's saying, please can we make sure that we think about how we optimize, in terms of how clinicians use these tools. And uPerform, I think, has a great role to play in helping new users and existing users with new functionality.
Thank you, David. And so, David, you often refer to uPerform as a great accelerator, right? Being utilized to expand the abilities of small teams, improving efficiency and output. And we saw this story play out with the decision by Cambridge University Hospitals to bring in uPerform to help their training team, allowing them to just do more with the small team they have and accelerate the creation of their learning content as well as their training delivery. Are there any other ways that you foresee uPerform benefiting those who will be utilizing it, not just the training teams?
Well, yes, because, as you've heard me say before, I'm really excited about the workflow support and acceleration or catalyst role that uPerform can play in terms of all sorts of workflows. It's the field is wide open here in this discussion because, we're not talking just about workflows that EPR systems typically come with, and we're all familiar with, like, documenting, care, scheduling care, prescribing drugs, ordering tests and communicating with. So these are common and important workflows. But and I think the challenge here, or the proposition here, is that uPerform, kind of in a unique way, has this ability, I think, if the organization that's using uPerform configure it so they can direct uPerform's capabilities towards the whole user base in complying with not just the functionalities I've just mentioned, but the more kind of high priority workflows of the day. And we're going to be talking about this, I think, in a minute. I mean, the latest priorities of the day have actually been published, as we know, in the so-called planning guidance for 25-26. And I mean, we'll go on to maybe explore those in a minute, but we know, not surprisingly, that the prevailing climate is around improving and reducing waiting times, increasing access, improving productivity, living within the budget. So these are just some of the priorities, no surprise, that have been emphasized by central government and NHSE. And so what I'm saying is, even these more topical and current urgent priorities can be helped by uPerform. How would they do that? Well, for instance, in waiting times, one of the of course ways to help waiting times is to increase capacity, to increase elective throughput. Increasing capacity, as we know, means that patients need to be treated in the right place, not always in the hospital. So a big effort is about keeping patients out of the hospital and in virtual wards. Doing that requires staff to comply with policies and with how the EPR system is configured to refer patients and treat patients that are on hospital at home or virtual ward beds. And similarly, in ED, another waiting time target is to reduce, increase the 4-hour waiting time percentage. Doing that is also dependent on SDEC, or same-day emergency care. Now, that's a new initiative over the past couple of years. I know from working at a recent trust in the South, trusts still get confused as to how to refer patients to SDEC units. Okay, so that patients are treated, for emergency care on the same day, those that are suitable for those units. But that can only be done if staff know which patients to refer to these areas, and here again, that's a workflow. And again, this is just an example that I thought up at the top of my head, that uPerform could potentially be used to help hospitals direct patients to the right care locations to maximize capacity to meet central targets.
And I think, David, what's interesting for me there is that you're alluding to just one example in that case, but I think there's thousands of these changes coming at clinical teams. And if the NHS is going to dig itself out of this, challenging position it finds in, it's got to change the way it delivers services, really significantly. And that comes clear in the planning guidance, but it's been clear if anybody's listening to anybody's speech on any stage for the last 2 or 3 years that we're at that brink now. We've got to sort of step off and begin to make those changes. And I think, that is immensely challenging for frontline clinical staff who's, are already spinning 1,000 plates every day to keep the services running. And you're asking them to change the way in which they work and yet stay within safety guidelines and so on and so forth. So it's clear we've got to put tools in place to make that tough journey as easy as it can be, because I think it's going to be really difficult for these folks to sort of make these changes, especially with funding background and all the rest of it. So in truth, I think any tool that is capable of greasing the wheels a little bit and making that journey a little bit easier is is going to be worth the investment, both emotional and financial, frankly, because it commits us to a brighter future.
Smart tools like uPerform, I think has such a big role to play. Wherever I go and advising EPR implementations, I mention it. And so I think it will, I'm hoping and I'm expecting it to be taken up more widely. But I mean, just going back to your point about the people, I just read today in the HSJ comment from Steve Black. I don't know if you read him. I think he's brilliant. But he was making a point today that, even with the new planning guidance, there's hardly anything about the digital workforce. A digital workforce plan has been promised, apparently, by NHSE, but it hasn't been forthcoming. And so, that's another challenge in the environment that we're working in. But yet we all agree that, and the center apparently also agrees that a digital workforce is essential to making the productivity changes and meeting the priorities. And yet there's very little detail about it. So I think, what does that mean? Well, I think we need to do what we can in the absence of central guidance for building a digital workforce. And I think this is another example of how we could build, if you like, a digital workforce to implement all these new changes. You're right. You're so right, Andy. I mean, I think everyone I speak to, they just recognize, but they scratch their heads about how we're going to fit all these things into this limited, bucket. But everybody just keeps chucking things into it, expecting things to be done.
Yeah, well, I'm slightly reminded though of the period when the sort of coalition government came in 2010 and they kicked off that austerity program. The economy couldn't afford public services at the way. The primary focus initially was around local authorities, and in those first 3 or 4 years of that program, I know later on it cut deep and did damage, but it's certainly in the first 2 or 3 years. My sense was local authorities started facing up to changes that they perhaps recognised they needed to do, but the financial pressure wasn't so severe that they were willing to sort of take the leap. And I do wonder if the NHS is reaching that point now where, the money is going to be so tough over the next, 2, 3, 4 years that change that people have found difficult will suddenly become, slightly more palatable or frankly, the only way that they are going to keep a sort of service going and things like that. And I think I feel like I'm seeing little sort of green shoots of some of that. Certainly some of the levels of collaboration we're witnessing across organizations, that would have been hard to achieve previously, and yet now it's becoming possible because otherwise they'll all go to the wall. So we might as well work together and collectively survive. So I'm sort of feeling like as long as it doesn't carry on in the way that austerity carried on in public services, in local authorities rather, and let's face it, cause some real damage to in the end to social care. I could see a couple of 2 or 3 years of this being quite healthy in a way. It might open people's eyes to the opportunities that they've previously not really had to embrace because they've had the budget to survive in the old way.
Yeah. Well, I'm going to just quickly tag on to your point about collaboration, because I was in a workshop last week, a really good one in Essex, where there are 2 trusts who aren't about to merge, but who have come together to implement, a single EPR system. This is happening up and down the country. And so, your word collaboration, so it's all about collaboration. But what it means on the ground practically is that one of the 2 trusts is going to take probably the EPR system from that the other trust is using, which means a whole bunch of training. Yeah. Right. I mean, thousands and thousands of staff are going to be training as a result of collaboration. So which is a good thing and a necessary thing, but it's another angle, which from which to see how digital tools are going to be ubiquitous, but training and their good use of them will be essential. Again, uPerform can play a role.
Right. So it sounds pretty clear, right? You both mentioned planning guidance that came out recently, that 25, 26 will be a challenging year. And it's clear that we all must live within our means. I think it's never been more important that we continue to ensure that taxpayers' money is spent wisely, and this will require this relentless focus on operational performance, recovering productivity, tackling unwarranted variation, and things like reducing delays and waste. So with these limited resources and an enormous weight to carry, it kind of seems like the NHS will need to really lean on tools that can help them scale operations, prepare the digital workforce. If it was up to you guys, how would you address these challenges and make the NHS sustainable now and for future generations? Andy, let's start with you.
Yeah, well, I mean, it kind of reiterate what I was saying, really. I mean, I think one way or another, the NHS needs to find a way to survive and even thrive within its existing envelope. And I mean, in England, it's getting £160 billion a year, so it's not like it's a small envelope. You know, there is a big old chunk of cash there, and if we can be imaginative and innovative in the way that we spend it, if we can drive out the benefits of the types of collaboration David's described. I mean, you know, that example for Essex, I dare say 5-10 years ago, those two trusts would have been deliberately doing something different, because that was the NHS mantra. You did different to the guy down the road. Now we're starting to see people work together, 7 or 8 trusts across the East Midlands, all buying the same EPR. You know, all of Lancashire coming together to buy the same. You know, there's sort of real examples of that benefit, you know, being driven out. I think the other narrative that I'm picking up increasingly is, I guess, a challenge to the traditional leadership, both at national level in NHS England, in our regulatory bodies, you know, in MHRA and in NICE and so on, and indeed in some of the frontline organisations, around their risk appetite on digital solutions. So, you know, people are beginning to challenge them about the fact that they have been sort of resistant to pushing a digital solution into a space until it is, you know, absolutely proven beyond all doubt that it will, you know, add benefits, deliver ROI, all of these things. And I think there's, you know, I heard a couple of talks recently where people were sort of challenging that a little bit and saying we need to start embracing this idea that technology is reaching a point where it can substitute for some of the clinician work that has gone on previously. And indeed, what we've seen in other sectors and other industries is where work has been shifted to the customer base, from the industry side, in a way that actually empowers those customers. So I think we're starting to see, I don't know, the NHS genuinely waking up to the fact that, you know, that change is an absolute necessary to you know, to survive. And I'm sort of interested in helping find the tools, and I think uPerform one of them, that can make that change, you know, more sort of you know, more palatable. And I'm sort of reminded, I mean, it's a bit of a cliche to quote this story now, but if you think about the you know, the track cycling team at the Olympics, the British track cycling team, you know, back in the day at the Olympics, you know, we didn't win a single medal in track cycling for 76 years. And then we went to Beijing in 2008, and we won 7 of the 10 gold medals on offer. How did we do that? Well, Dave Brailsford and the team applied the theory of marginal gain. If you look for a tiny little bit of improvement, the 1% improvement across every single aspect of what you do, then that adds up to enough collective power to drive, you know, change and deliver success. And I think that's the point the NHS is at. It's got to find thousands of little marginal gains across everything it does to you know, to improve the service and to keep it going, you know, into the future. And I think, you know, the collaborative stories David's describing are one example of that being driven out. I would say the adoption of different technologies are an example of that. You know, putting uPerform in to support your and change the way that you approach training is an example of that. And there needs to be loads and loads and loads of these, one after another, happening to get us to a place where our health service for our country is sustainable into the long term.
Well, yes, and so I absolutely agree. It is about, one of the planning guidelines is about living within the budget, and there's no new money. And so I think we need to make the efficiencies, little efficiencies everywhere. But I mean, just getting back to the guidance. So, and so just getting back to the guidance, and I'll tie it into that thought, which is that the guidance has, some main priority headings, which is about waiting times, as I mentioned. It's about access to GPs, dentists and GPs, and it's about quality, although they focus on maternity and neonatal. It's also about there's a priority on making services more local and at the neighborhood level, and there's productivity, which they say is really around reducing length of stay, which is about optimizing capacity and reducing costs. There is a big priority around staffing, and then there are various challenges that they note along the way, including estates and an aging population. And really, so I guess my basic thought about how uPerform could address these priorities is to ask an intervening question, which is how can digital or maybe EPR systems as a main example, how can EPR systems address these priorities? Because anytime an EPR system can help these priorities and deliver these priorities, I think uPerform can help staff use the EPR system. That's my basic, premise. And to give you an example, I gave an example under waiting times, but another example about waiting times is that, there is this thing called virtual nursing, which is being supported by EPRs, where there are cameras by the bedside with nurses looking after, augmenting bedside nurses through remote cameras. And so that now is being integrated with EPR systems, and use of virtual nursing as an example in EPR systems has been proven to decrease admission times and increase the number of discharges by noon, which increases, capacity and makes beds available. So that's an example of how EPRs can work with a virtual nursing program. And of course, what that means is staff will need to be trained to use EPRs to support virtual nursing. And of course, uPerform can help there. Another example, just to give one more, is on access. So obviously, patients want to be able to access their outpatient clinics and hospitals rapidly. Well, I think the use of the patient portal, so Epic happens to have a very good patient portal, but they're not the only one that has one. But the Epic patient portal, we know through MyChart, as it's called, can help patients to manage their outpatient appointments. In fact, they can select an option so that they can say, yes, let me have the next outpatient appointment that gets canceled, and I'm willing to take that slot. Okay, and that's an example of how EPRs can help meet that planning guidance. uPerform can help staff use the EPR system, or in this case, use patients and EPR staff to optimize that functionality. And the last one I'll give is around the aging population. So that's a key consideration in planning guidance, going forward many years, as Andy says. An aging population in NHS terms means multi-morbidity, which in turn means more concurrent pathways for long-term conditions like diabetes and COPD and depression, which, I speak to my clinician friends, it's very common for patients to be on each of these pathways at the same time. And so that requires EPR functionality, which then in turn will require staff and clinical staff to be trained to use pathway functionalities, for concurrent pathways, which will have a big training component.
I tell you what I like in that list, David, is the ones where we start to empower the patient and give them access to their information and ability to sort of control their care pathway in the way that we've not done before. And I think the NHS has been dreadfully slow in truth in noticing what has been happening in banking and travel and all of these other industries, where they have cleverly shifted work to their customer in a way that the customer is empowered. I said on stage the other week, I should be on the payroll at EasyJet. I do that much work for them when I'm booking a flight, these days. And but I think it's really clever. I feel like I'm in control of my own sort of destiny in that element. And I've seen stuff recently about the way the NHS app is going to develop, and that's the direction it's going, is to utilise and empower in the way you've described there with MyChart. And I think, that's one of the ways we will take the burden off the NHS to allow it to survive and thrive, is to give some of the work, but in an empowering way, to those people we serve. And I think that will require, support for NHS staff and for the public in training to utilise those tools. And so, there's a role there for uPerform to support that, I think. So, great list.
Wonderful. Well, Andy, David, many thanks for taking the time to share your background and expertise and provide insights on how the NHS can look to improve and optimize its use of technology to meet the broader needs. It's clear these challenges the NHS is facing won't be solved overnight. However, with the support of a government focused on investing in our national care system, I think the NHS has an opportunity to drive meaningful change and better position itself as an innovative and digitally savvy healthcare provider. I specifically liked, Andy, your example of the British cycling team and the way that many small incremental changes can lead to great results. And we here at uPerform like to think that uPerform is one of those solutions that brings these small and incremental changes. So if our listeners would like to learn more about uPerform and how uPerform is helping health systems around the world save time spent in training while improving EPR satisfaction and efficiency, please visit our website at www.uperform.com. Thanks everyone for participating in this podcast, and thanks everyone for listening.